Hello, I'm Eric Strong from Strong Medicine, and today in this ongoing video series on an approach to symptoms, I'll be discussing an approach to acute nausea and vomiting. For this video, I'll be focusing on those conditions in which it's common for nausea and vomiting to be a primary symptom, rather than those conditions in which nausea and vomiting are just minor manifestations of a much broader symptom complex. To understand the diagnostic framework, it's helpful to know just a little bit of the relevant physiology. The part of the brain responsible for integrating signals throughout the body and converting them into the sensation of nausea and initiating the vomiting reflex is predictably called the vomiting center or the emetic center. The vomiting center, along with the chemoreceptor trigger zone from which it receives signals, is located within the medulla. The most obvious sources of pronausea input are the GI tract via the vagus nerve and the vestibular system of the inner ear, but there are several others. For example, nausea and vomiting can be triggered by sensory receptors within the pharynx, as well as those from the heart, most classically observed in myocardial ischemia. Metabolic derangements and some medications directly stimulate the chemoreceptor trigger zone. Meanwhile, the cerebral cortex, where conscious thought occurs, both delivers signals to and receives signals from the vomiting center. The limbic system of the brain, which is normally involved in emotion and memory, can also play a role in triggering or modulating the subjective sensation of nausea. Once stimulated by one or a combination of multiple triggers, the vomiting center initiates a number of physiologic changes. It relaxes the smooth muscle of the stomach, it increases pyloric tone, decreases lower esophageal sphincter tone, closes the glottis and vocal cords to prevent aspiration, the soft palate rises, and last, the abdominal wall and diaphragm contract in order to expel gastric contents. So when we are considering the possible sources of nausea and vomiting, that is, their etiologies, we can use some of these same categories. Starting with GI, which is the most obvious and most common overall category, etiologies can be further subdivided into infectious versus non-infectious. One infectious etiology is food poisoning, though this isn't really an infection strictly speaking. Food poisoning is caused by the ingestion of toxins that were produced by bacteria in the food prior to consumption, most classically caused by Staph aureus in food left at room temperature for long periods of time, like one might find at a picnic, potluck, or poorly maintained buffet. Infectious etiologies also include both viral and bacterial gastroenteritis. Non-infectious GI etiologies include almost every itis in the system, meaning esophagitis, gastritis, pancreatitis, cholecystitis, or inflammation of the gallbladder, acute hepatitis, or inflammation of the liver, and appendicitis. The only major itis in the GI system which does not usually cause prominent nausea and vomiting is colitis, which is inflammation of the large intestine. Other non-infectious causes are small bowel obstruction, for example from intra-abdominal scars from prior surgery called adhesions, and peptic ulcer disease. Moving to the vestibular system, there are four major causes here, all of which are associated with vertigo, in addition to nausea and vomiting. Vestibular neuritis is self-limited inflammation of the inner ear, believed to be viral in origin. If hearing is affected in addition to vestibular function, the condition is referred to as labyrinthitis. Benign paroxysmal positional vertigo is caused by free-floating debris within the semicircular canals, resulting in a characteristic abrupt worsening of symptoms with particular head movements. Otitis media is an infection of the middle ear. And last, motion sickness. Next category is the central nervous system. Concussions from head trauma can cause nausea and vomiting, as can any cause of increased intracranial pressure, such as tumors and hemorrhage. Metabolic causes include diabetic ketoacidosis, uremia from kidney failure, hyponatremia, hypercalcemia, and adrenal insufficiency. There are a large number of medications and drugs associated with nausea and vomiting. Although these could all be redistributed to one of the other categories in this diagnostic framework, I think it's useful to keep a separate category for them. Most notable here is chemotherapy. Literally any drug that is conventionally thought of as a chemotherapeutic is a common cause of nausea and vomiting. Among commonly used chemotherapy, those with the highest risk of nausea is cisplatin and carboplatin, cyclophosphamide, doxorubicin, and ifosfamide. About 1/3 of patients who undergo general anesthesia will experience nausea in the 24 hours following the procedure. Other drugs with a high rate of nausea include opiates and all antibiotics. The substance of abuse most likely to cause nausea is alcohol. Our last category is miscellaneous. In this category, we have pregnancy. The majority of pregnant individuals will experience nausea and/or vomiting at some point during their pregnancy, with an onset in the first trimester. Usually, this is frustrating and uncomfortable, but does not require treatment beyond oral antiemetics. However, when the nausea and vomiting is intractable and is associated with hypovolemia and weight loss, sometimes requiring hospitalization, the condition is termed hyperemesis gravidarum. As mentioned earlier, myocardial ischemia can lead to nausea, which is an example of what is known as an anginal equivalent, meaning that its unexplained presence in an older patient or in one with cardiovascular risk factors should be approached the same way that chest tightness is, with an ECG and a troponin. A hypersensitive gag reflex can cause nausea and vomiting. Last are a variety of psychiatric conditions, including panic attacks and conversion disorder. Although I've been unable to locate data on this, in my personal experience, among all of these potential etiologies, the ones that are particularly common to cause presentations characterized by prominent nausea and vomiting are food poisoning, viral gastroenteritis, pancreatitis, appendicitis, small bowel obstruction, a concussion, any of the medications or alcohol, and pregnancy. How do we evaluate a patient with nausea and vomiting? The duration and pattern are important. For example, episodes that are worse in the early morning are characteristic of pregnancy and any cause of increased intracranial pressure. And if the nausea and vomiting have been lasting for more than several weeks, or are a manifestation of recurrent episodes with asymptomatic periods in between, switching to a framework for chronic nausea and vomiting is more appropriate. What's the character of the vomit? Bloody vomit is called hematemesis and suggests upper GI pathology such as esophagitis, gastritis, or peptic ulcer disease. However, some of these patients will have a Mallory-Weiss tear, in which repeated vomiting causes a tear in the inner lining of the esophagus, which is then responsible for the bleeding. In other words, the cause of the nausea and vomiting and the cause of the bleeding are not necessarily the same thing. Vomit that contains material resembling coffee grounds is suggestive of the expulsion of partially digested older blood. Feculent vomit, that is, vomit that looks and smells like feces, is strongly suggestive of distal intestinal obstruction. Now, there is sometimes a distinction made between bilious vomiting, meaning green bile is mixed with the vomit, versus non-bilious vomiting. However, I have not found that distinction to be diagnostically helpful in adults. Even if the patient has esophageal or gastric pathology, the vomiting reflex can propel contents of the small intestines backwards too. Now, while it's true that the vomit observed in a gastric outlet obstruction is classically non-bilious in nature, appearing to give some value to this characteristic, gastric outlet obstruction is simply not a common pathology outside of pediatrics. Next, ask if there are any associated symptoms that might point to a specific etiology. For example, abdominal pain obviously points towards a GI pathology, but metabolic etiologies of acute nausea and vomiting also cause abdominal pain. Diarrhea suggests infectious causes, while constipation, or more accurately, lack of bowel movements, suggests a small bowel obstruction, as does abdominal distension. Headache suggests primary CNS pathology. As mentioned earlier, vertigo or hearing loss suggests pathology in the vestibular system. Concurrent chest, arm, or jaw pain, dyspnea, and diaphoresis all suggest myocardial ischemia. Has the patient been around others who have had similar symptoms, such as multiple attendees at a social function, which would suggest a foodborne illness like food poisoning? Obviously, ask about their past medical and surgical histories. What meds are they currently on, focusing on changes in the days to weeks preceding the onset of symptoms? And ask about substance use, particularly alcohol. The focused exam in acute nausea and vomiting should include vitals, obviously a thorough abdominal exam, a retinal exam to look for papilledema, which is swelling and blurring of the optic disc secondary to increased intracranial pressure, keeping in mind that it may take a day or even longer for papilledema to develop after the onset of increased ICP. A screening neural exam, which is a subset of the complete neural exam, which can identify the majority of occult neural findings, and with practice can be performed in 5 minutes. One thing to pay particularly close attention to during the neural exam is nystagmus, which suggests vestibular pathology. And cardiac and pulmonary exams, particularly if the patient is older and/or has cardiovascular risk factors, or has concurrent cardiopulmonary symptoms, such as shortness of breath. Relevant tests that can be ordered include a complete metabolic panel, which can identify electrolyte abnormalities, kidney failure, liver failure, and biliary system pathology. An elevation of lipase to more than 3 times the upper limit of normal is specific for pancreatitis, though lesser degrees of elevation can be seen in a variety of gastrointestinal pathology. A pregnancy test in women of reproductive age, a stool test called the GI PCR panel that can identify the presence of a large variety of pathogens. Imaging is frequently ordered. A very common question in the initial evaluation of these patients is exactly which imaging test should be ordered, so a CT scan or an ultrasound. If the patient's condition warrants imaging, as a very general rule, if you are more concerned about liver or biliary pathology, or if the patient is pregnant, start with ultrasound. Otherwise, start with a CT. Upper endoscopy is sometimes performed, particularly when the patient has bloody vomit or when there is associated epigastric pain but with an unremarkable CT scan. If there's any concern about the possibility of cardiac ischemia, as mentioned, obviously get an ECG and troponin. And if there is concern about intracranial pathology, brain imaging is obtained. MRI scan can identify more pathology than a CT scan, but a CT is much faster and more widely available. Now, how can we put all these questions and tests together into a diagnostic algorithm? Every adult presenting with prominent acute nausea and vomiting needs a history, a physical exam, a complete metabolic panel, and lipase. In addition, if the patient is female of reproductive age, get a pregnancy test. And if the patient has cardiovascular risk factors, including advanced age, concurrent chest pain or dyspnea, or low blood pressure, get an ECG and troponin. Sometimes, after this initial evaluation, a specific diagnosis will be already strongly suggested, in which case continue a focused evaluation as appropriate for that suggested diagnosis. For everyone else, the next step in the workup will depend on features of their presentation. So, for example, if the patient has any combination of fever, feculent vomit, or significant abdominal pain, tenderness, and/or distension, the next step is a CT scan. The one exception to this might be the relatively young, healthy patient who presents with acute nausea and vomiting and either generalized or epigastric abdominal pain, but the abdominal pain is relatively modest and the patient is with an otherwise normal exam, including vitals and normal or near normal labs. This patient probably just has food poisoning and abdominal imaging is not necessary. If the patient has hematemesis or so-called coffee ground emesis, they need an EGD, the urgency of which depends on their hemodynamic stability and the apparent speed and volume of blood loss. In years past, this question was often answered with nasogastric lavage, but this bedside procedure has fallen out of favor on account of physical discomfort, a non-trivial complication rate, and the impression that information gained from it did not actually impact the timing of EGD in practice. If diarrhea is also present, it suggests viral or bacterial gastroenteritis, in which case you should collect a stool sample for a GI PCR panel. If the patient has specifically right upper quadrant pain, jaundice, and/or abnormal liver function tests, obtain a right upper quadrant ultrasound and a hepatitis panel, which refers to a non-standardized collection of 4 to 6 tests looking for antigens and antibodies for hepatitis A, B, and sometimes C. If the symptoms are worse with movement and the patient has vertigo and nystagmus is present on exam, perform the Dix-Hallpike test to evaluate for BPPV, and perform a quick specialized exam called the HINTS exam, which stands for Head Impulse, Nystagmus, and Test of Skew. These exam maneuvers are discussed in my video on an approach to vertigo. And if the patient has a headache, recent history of head trauma, papilledema on retinal exam, or focal neural findings, they need brain imaging. While every case is different, I'd say that in general, if a patient's presentation has features that span more than one grouping here, they should receive all the indicated tests in those multiple groups, unless a diagnosis is made beforehand. For example, if a patient has not only a fever and abdominal tenderness, but also diarrhea, they should probably get both a CT scan and a GI PCR panel. Two last big caveats. First, just because a person is pregnant does not mean that their nausea and vomiting can't be from something else. So the workup should not automatically end after a positive pregnancy test. And second, when working up acute nausea and vomiting, one should also consider the possibility that this is an initial presentation of a cause of chronic nausea and vomiting, which is the subject of another video in this series. The key takeaway points of this video: nausea and vomiting can be caused by pathology of the GI system, vestibular system, brain, heart, metabolic derangements, medication side effect, or psychiatric illness. Common causes of acute nausea and vomiting include food poisoning, viral gastroenteritis, pancreatitis, appendicitis, small bowel obstruction, a concussion, chemotherapy, anesthesia, and pregnancy. In addition to the history and exam, the most important initial tests that patients should receive when being worked up include a complete metabolic panel, lipase, a pregnancy test if the patient is a woman of reproductive age, and an ECG with troponin for patients with cardiovascular risk factors or other symptoms consistent with cardiac ischemia. That's it for this video on an approach to acute nausea and vomiting. If you found it interesting and helpful, consider subscribing to Strong Medicine for more videos on medicine and medical education.